Welcome to this expert explainer presented by Dr. Christophe Delong and Kinexa Formation. Today we're unpacking what I can only describe as a total paradigm shift in medicine. I want to hook you right out of the gate here. The idea that you absolutely need complex, hyper-expensive machines to accurately assess fracture risk, well, that's changing. Actually, scratch that. It's already changed. It turns out your own clinical skills, your eyes, your ears, your judgment, might just be the single most powerful diagnostic tool you have in the room.
Okay, let's take a quick look at our roadmap. We're going to cover the power of clinical evaluation, visible clinical signs, the targeted patient interview, functional and physical evaluation, tracking progression, and finally, a holistic and accessible approach.
Let's dive right into Section 1, the power of clinical evaluation.
Now, you might be wondering, is relying on just clinical observation some kind of fringe theory? No way. It is the global gold standard. Think of a DXA bone scanner like the check engine light on your dashboard. Sure, it tells you something is off, but you still need the mechanic's hands-on inspection to actually diagnose the real problem, right? The heavyweights in global health, we're talking the World Health Organization, the IOF, the USPSTF, they all explicitly affirm that assessing fracture risk absolutely has to start with observable clinical data before you even think about ordering up an instrumental scan.
Just take a look at this. The WHO stated back in 2007 that clinical factors independent of bone density are often more predictive than bone mineral density itself. I mean, let that sink in for a second. That's incredibly empowering. It literally means that the patient's context, their personal history, and your direct face-to-face evaluation actually carry more predictive weight than a single isolated number spit out by a machine. Moving right along to Section 2, visible clinical signs. So the very second a patient walks through your door, there are game-changing signs you can spot just by looking at them. In Dr. Delong's framework, and fully recognized by major authorities like the ISCD, things like dorsal kyphosis, that noticeable forward rounding of the upper back, that is a prime indicator of hidden vertebral fractures. Pair that with a height loss of more than 4 centimeters, and boom, you are staring at massive diagnostic red flags for systemic bone fragility. And the best part? Zero radiation required. Just your keen observation. But it doesn't stop there. We also have these really crucial physical markers. A low BMI coupled with a slender morphotype, noticeably reduced muscle mass, or even just general postural fatigue. These are all totally independent risk factors validated by the WHO and the NIH. And get this, the WHO actually considers mechanical spinal pain in older adults to have the exact same clinical value as certain densitometric markers. Why? Because it correlates so incredibly highly with undiagnosed fractures. All right, let's transition to Section 3, the targeted patient interview. Now, what's really interesting about this next part is how we reframe the patient history. It's not just background noise anymore, it's a highly tuned predictive tool. We're talking about the critical WHO-validated risk factors. Things like previous fragility fractures, parental history of hip fractures, prolonged steroid use, or lifestyle factors like alcohol and tobacco. These specific variables give us such immense predictive power that they literally form the bedrock of all international guidelines. By simply structuring your conversation to capture these exact data points, you are actively performing an internationally recognized risk assessment. You really don't need some complex black box algorithm to figure out a patient's risk profile. You just need to ask the right targeted questions. It completely grounds your medical practice in solid, irrefutable evidence. If you take nothing else away from this segment, please remember this absolutely crucial point. If your patient has had a previous fragility fracture, you already possess your single most important piece of data. Period. Every major authority agrees that this is the best, most powerful predictor of future risk out there. It often completely eclipses whatever densitometry data you might get later. So be confident. Trust the patient's history to guide your next steps. Moving on to Section 4, functional and physical evaluation. Okay, so we've observed, we've interviewed, and now we move into action. We have to remember that a fracture is basically a collision between two things, bone fragility and a fall. You just cannot assess fracture risk accurately if you aren't assessing fall risk. It's like trying to solve a puzzle with half the pieces missing. That's why functional assessment is absolutely non-negotiable according to both the IOF and the WHO. Assessing their gait, checking their balance, digging into their history of falls, that is central to the entire diagnostic picture. And honestly, the absolute best part is how incredibly simple these tests are. You can do them right in your office. Step 1 is the timed up and go test, or TUG. You just measure the time it takes them to stand up, walk 3 meters, turn around, and sit back down. Step 2, the one-leg balance test, a fantastic quick indicator of stability. And step 3 is the chair stand test, where their ability to stand up without using their arms gives you a direct functional measure of lower limb strength. 3 simple tests, a couple of minutes, and you've got hard data on stability, fall risk, and muscle strength. Which brings us to section 5, tracking progression. Now, you might think you need fancy equipment to track a patient's progress over time, right? Well, you don't. When you observe improved motor coordination, better postural stability, or just greater symmetry in how they move, you aren't just making some subjective shot-in-the-dark guess. These are officially validated metrics for qualitative observation, completely recognized by major organizations like the American College of Sports Medicine. In fact, the CDC notes that your keen clinical observation can sometimes identify fall risks and track functional improvement even earlier than highly instrumented expensive systems. When your patient can perform their daily movements with more ease, more stability, and better control, they are improving. It's that simple. You are fully equipped to measure that success purely through your own clinical expertise. Let's bring it all home in section 6, a holistic and accessible approach. This slide right here perfectly encapsulates Dr. Delong's core thesis. Fragility is not just bone density. That's a really outdated single metric way of thinking. True multifactorial fragility is the intersection of these 4 vital circles: bone health, muscle strength, balance, and mobility. If you ignore even one of these, you just aren't seeing the whole patient. And the global consensus is completely on board with this holistic view. By combining clinical observation, targeted questioning, and functional analysis, you're providing a deeply reliable bone risk assessment. This integrated approach fully meets international recommendations, and in the vast majority of clinical situations, it successfully replaces the function of a DEXA scan. You are finally treating the whole person, not just a scan result. Which leads me to a really provocative question, especially when we look at the realities of modern healthcare. Why not do this remotely? Seriously, think about it. If this entire highly validated methodology relies strictly on what we can see and hear, why do we force mobility-impaired, fragile patients to travel into a physical clinic every single time? We don't have to. Because this approach relies on vocal interaction for the history and visual observation for movement and function, it perfectly unlocks the power of telehealth. High-quality video and clear audio are more than enough to perform a comprehensive, internationally compliant evaluation. It eliminates travel barriers and makes holistic care universally accessible. So I'll leave you with this thought to chew on. How will you use your newly empowered clinical observation skills to transform the reach and impact of your own practice tomorrow?